So I guess the small correction is that a lot of my work deals with problems of making individual inferences to individual patients from group data. Because it seems to be that could be a tough nut to crack. So I'm going to just give some very broad conceptual scene-setting discussion for heterogeneity of treatment effect in 10 minutes. None of the work that I show is really based on any original work. And the first person I'd like to acknowledge is this person, Bill Wennington, because he gave the name to something that I call the Wennington Fallacy. So I think the Wennington Fallacy is a fallacy. I think it undermines, evidence-based medicine is in some ways based and undermined by the Wennington Fallacy. Some people might know it as the fallacy of division. And I'll just tell the story is that in 1995 in the conference championships of the NBA, he was on the team with Michael Jordan, Scottie Pippen. He scored the winning basket against the Knicks in Game 5 in overtime. And at the end of the game, he was interviewed, and he boasted Michael and I combined for 57 points. Now, the punchline can be seen in the box score. You could disaggregate those results and see that Michael scored 55 points and Bill scored 2. Now, of course, so I call this the Wennington fallacy. The lesson is that you can't look at the aggregated results of a group and then make inferences. It's dangerous to make inferences to the individuals in that group. Yet that's essentially what we do all the time. We take group data, we measure treatment effects, and then we make inferences to the individuals in that group. What we really want is the individual treatment effects, but to be honest, there are many conceptual problems with individualized treatment effects. One of the main problems is that it's inherently unobservable because you can't measure the outcome in a patient that's simultaneously both on and off treatment. And so this is what the box score looks like in a clinical trial. You can't really disaggregate the results in a certain respect, and I'll show you what I mean. So just to, I'm sorry, is there a pointer that I can use on the computer or no? Or, well, anyway, I'll just do it here. The zeros and the ones represent good outcomes. 0 represents good outcomes, alive. 1 represents bad outcomes, let's say dead. The key to understanding benefit and harm is in the lower left-hand corner. And that's if you know what would happen to a patient without treatment and with treatment. You could tell if the patient's benefiting, harm, or if there's no effect. And this is all in a deterministic framework. But if you look at the results, for any given patient, you can't really tell if they've benefited or harmed. So Ben, for example, has a good outcome with treatment, but you can't tell if he benefited because the effect could be null or benefit. Mohammed, on the other hand, has a bad outcome. You can't tell if he was harmed. Again, it could be harm or no benefit. Now, if we were able to actually magically to examine the counterfactuals, then you'd be able to tell that there were 2 people who were harmed and there were 4 people that would benefit. And I hope we would agree that even if this is unpredictable, that this represents heterogeneity of treatment effect. Some people actually don't agree with that, but in actual fact, we really can't identify those patients who benefit. And instead, what we get is something that looks like this, where we measure, we take one group of patients, we withhold therapy, we measure the outcomes in each of those, we take another group of patients, we give them treatment, we measure the outcome in those, we count up all the outcomes, we get a proportion, and we measure the benefit here by comparing these proportions. And then we conceptually describe the treatment effect in a probabilistic or stochastic way, and we apply that back to the individuals, and we substitute that for kind of an individualized treatment effect in some way. And then we might do some subgroup analyses. We might divide patients male versus female, old versus young, and whatnot. And those are the results of those subgroup analyses will invariably be, one of two things. They'll either be null or confusing, and we'll say, well, everybody gets the same benefit. That's the way most clinical trials go. So this lengthy introduction is just by way of saying that my belief is that heterogeneity of treatment effect is in fact ubiquitous, and that our failure to detect it represents just that. It's a failure of science. So, and I'll totally concede that that's a faith-based belief. There's really not necessarily a lot of evidence there, but it's consistent with the evidence, just like I know other people disagree with it. So then the question is, why do we fail to reliably detect heterogeneity of treatment effect if it's so ubiquitous? Well, there are a lot of different reasons we might fail. It could be a failure of the data that we have. In other words, the observable covariates are totally unrelated to the causal determinants of heterogeneity of treatment effect. Or the causal mechanism might be so complex that the variation in treatment effect just ends up looking like statistical noise. But there might be more addressable analytical issues. So power is very low to detect heterogeneity of treatment effect. So the fact that we don't find it is no surprise, and not really, to my mind, strong evidence of homogeneity of treatment effect. We need probably orders of magnitude larger to really see if it's there or not. And also, there might be some limitations of conventional subgroup analyses, what I call one variable at a time subgroup analyses. So what are some of those limitations? Well, and what are one variable at a time subgroup analyses? Basically, we compare males to females, old to young, those with hypertension to those without, those with diabetes to those without. And those are really comparing groups of patients that differ systematically on only a single variable, but patients in real life differ on multiple variables simultaneously. So these analyses really don't represent the full heterogeneity of the patients that are available to us that might be relevant for measuring heterogeneity of treatment effect. And then the other issue, of course, is that there are just so many characteristics that patients have that might affect either the risk of the outcome of interest or the treatment benefit, that to serially test one variable at a time just leads to multiplicity. And then we can't even trust the effects when we see them. So I'm not actually going to cover this. This just shows that experts can that subgroup analyses tend to be confusing and that experts can disagree on how to interpret them. And the reason is because they're often not credible. There's a long history, as other speakers have said, of positive subgroup analyses from clinical trials that have influenced clinical practice and then subsequently shown to be false. This is from a review article by Peter Rothwell from The Lancet, who's done a lot of thinking on this issue. Okay, so this is my interim summary. Overall results of clinical trials can be misleading and miss heterogeneity even if it was ubiquitous. Overall results of clinical trials can be misleading because there's often hidden heterogeneity. On the one hand. On the other hand, subgroup analyses of clinical trials are often inadequate and can be misleading when they're positive. So I promised Claudia that I wouldn't end on such a despairing note. And so I do have some recommendations about how, at least partially, to address some of these issues. And they fall into three categories. One is we need to just limit the number of hypothesis testing subgroup analyses. The other is we have to find ways to increase power. And the third thing is we have to look to always replicate and confirm our subgroup analyses when we find them. So in terms of ways to limit hypothesis testing subgroup analyses, we should use a hierarchical approach where we insist that investigators identify which of their subgroup analyses are clinically actionable and which are just fun to look at. So by clinically actionable subgroup analyses, I'm talking about hypothesis testing subgroup analyses or confirmatory subgroup analyses, and those should be few in number because they should be based on good empirical or evidence, prior empirical evidence. All the other subgroup analyses should be exploratory analyses, done not to motivate clinical practice, but to inform future research. The other issues about increasing power and replicating and confirming studies, one more issue is another method to essentially reduce the dimensionality of subgroup analyses is instead of using one variable at a time analyses, I'm a major advocate of using risk models to analyze clinical trial results. And others have mentioned this here today already, so I won't spend a lot of time on it. I don't have a lot of time anyway. But there are some articles in your packet where I try to make a compelling case that that approach should be done routinely in clinical trials. In terms of ways to increase power and replicate and confirm results of subgroup analyses, well, that's a lot of what we're talking about today, a re-engineering of the clinical enterprise to allow much larger studies, and we might need to have a higher reliance on observational studies and other methods like cross-evidence synthesis. So that's kind of the segue to the rest of this panel.
Okay, thanks. The next is Mark Klatke. Mark is a professor at Stanford. He's a cardiologist, and he studies methods for assessing effectiveness of treatment modified by patient characteristics. Just what we're interested in.